Hello, Gabby. Hope you're well. All right. I'm going to make a start just because this is probably going to go over today. Bear with me. Okay. All right, just quickly, we're getting renovations on our roof here, so please apologise for the banging and crashing that you might hear. Also, definitely we'll get to questions. Although this might go over half an hour, I'll try and make it be under half an hour, but I'm happy to stay for as long as necessary if anyone has any questions. So let's make a start. It's a full Q&A today, so we've got 16 questions. Now, Jacqueline asks about the causes of blisters. Well, this one's pretty easy. Friction blisters of the feet are caused by shear. What's shear? Shear is the stretching and distortion of soft tissues, and it happens because of moving bones in the presence of high friction force. So if that's a moving bone, let's say metatarsal head, that's the skin surface. High friction is keeping the skin surface still while the bones move back and forth, and all of this in between stretches and distorts, which is what this is. So that's the cause of friction blisters, and the repetition is an important part of that, in that obviously the more steps we take, the more likely we are to get blisters. This is a visual representation of friction. So we've got the bone of the metatarsal head moving to the right. Friction force is acting to the left. Now, friction force does not indicate movement to the left. Friction force is literally the force that opposes the other movement, which is the bone movement to the right. So we've got these opposing movement forces, and as a result, everything in between stretches and distorts. That's what shear is. Now, I'm going to explain or show you exactly how I explain blisters to really everyone, from my patients to podiatrists to pharmacists. I've been dealing a lot with those, with the pharmacy profession lately, and everyone gets it. So this is how I kind of suggest that you... Let me just get Emily in here. Okay, the way I explain it is this. Most people think blisters are caused by rubbing. They're not. They're caused by this, shear. Now, shear looks a lot like rubbing, but if you look closely, nothing is actually rubbing over the skin surface. But what is happening is all of this tissue, all of this soft tissue is stretching and distorting. So that's called shear, and that's what causes friction blisters. Friction blisters are caused by shear. The problem is when we think about it being all about rubbing, we think, cool, let's stick something to the skin, we'll eliminate the rubbing. That thing might be tape, it might be Compeed, it might be moleskin. Yes, you'll eliminate the rubbing, but what you haven't eliminated is shear. So shear is still happening in the skin underneath that dressing. It's still happening in here. But what we've done is we've spread it over a larger area, and that probably reduces it at its peak. So we've far from eliminated blister causing shear, and that's why people like me can blister in spite of having tape or a Compeed on. Two really effective ways, and we're getting into this next question from Janine, Sohaila, Juno and Will about how to prevent them. Two really effective ways of preventing blisters. One, gel toe sleeves or caps. Now, see this here? That is essentially the gel undergoing shear. Now, if the gel is undergoing shear, then there's less shear left to happen in the skin. So gel toe protectors are fabulous at preventing blisters. Another really effective way, it absorbs shear. Another really effective way of preventing blisters is ENGO patches. The way these work is they reduce friction, and it's important to understand what reducing friction actually means, because most people think it means less rubbing, but actually it means more rubbing, and it works like this. If this is your bone, it's moving back and forth within your foot with every step that you take, completely normal. In the meantime, the skin surface is staying still because of high friction force, also completely normal. What we can do is, although this is a completely normal thing and happens with every step that we take, if we're getting a blister here, we need to, or we don't need to, but we can reduce friction here. What that means is by reducing friction, you're freeing up the skin to move in sync with the bone at an earlier moment. And that reduces the magnitude of those shear distortions. So lubricants will do that. It will make it slippery at the skin surface so that that patch of skin can move in sync with the bone at an earlier moment. ENGO patches do it at the interface down. So lubricants between the skin and the sock, ENGO patches between the sock and the shoe, exactly the same effect. The skin is released to move in sync with the bone. The difference with the ENGO patches is we're allowing the sock to stay stuck to the skin, which I think is preferable. And we're getting that movement between the sock and the shoe. So that's how I describe prevention. And basically it necessitates a bit of a discussion on the cause. But there are many other preventions, and you can think of them like this. There's three main ways. Number one, you can reduce the number of shear repetitions. So that basically means take less steps. Now that's technically a prevention strategy, but not particularly helpful for anyone who wants to be active. On the far right in the yellow, we can increase the skin's resilience to shear. What that basically means is becoming familiar with the activity and the footwear. So breaking in your shoes, gradually increasing the distance that you walk or run so that the skin has time to adapt. It physically changes to become more resilient to shear. It's important to maximize this, but to also know that it can only go so far. So for some people, they can do training, do all the right things, break their shoes in and get gradually increase their loads, but they'll still get blisters. So it's important to then have something else to move on to and not blame the person because they haven't done their training properly. Most prevention products and strategies work here. They reduce the magnitude of shear distortions, and there's 4 ways to do that. So let's start on the far right, reducing bone movement. Bone movement is critical in blister formation. It's bone movement in the presence of high friction force. So let's say that if we're thinking about a metatarsal head, so that's the heel metatarsal head, so that's like an arch. If that's a flexible flat foot, so it's high when it's non-weight bearing, but it flattens on weight bearing, what's happening is those metatarsal heads are sliding forward as the forefoot bears weight. And then, of course, they're going to push backwards during propulsion. So we can do something about that bone movement. We could use orthotics. If arch flattening forces is coming from tight calf muscles or limited ankle joint dorsiflexion, we can do calf stretches. We can implement heel lifts, heel height differential on the shoe. So that's how we can have an influence on bone movement. And as podiatrists, we're doing this all the time. We probably don't really tie it into how we're helping blister management, though. Over here, we can spread shear. The way we spread shear is with adhesive materials. So this is your Compede and all brands of hydrocolloids. It's your moleskin and taping. Remember, when we spread shear load, we're not eliminating shear. We're just spreading it over a larger area. Most people, and including a lot of podiatrists, have an overinflated expectation about how effective this should be. Because they're still in the mindset that blisters are caused by rubbing, but they're not caused by rubbing. Rubbing is not the problem, and in fact, rubbing is often the solution. Rubbing is all about what this does, reducing friction force. So that's adhesive materials like tape. Then we can use materials like the gel toe sleeves to absorb shear. So I hope that's kind of understandable. And another example would be Spenco insoles. That 3mm Spenco has been found to reduce blister significantly, reduce blister incidence significantly, and is definitely worth a go for plantar blisters. And then finally, we can reduce friction force. We can do that in 2 ways. Essentially, friction force is determined by the nature of the 2 materials at their interface. So are they kind of grippy or are they kind of slippery? And then how hard we press them together. So it's like the vertical and the horizontal. The less hard we press, when we do this, if I press really hard, I get big shear magnitudes. If I press really softly, my fingertip can't help but slip over that skin before shear can build to any magnitude. So that's the compressive force or pressure. And then if I put a blob of Vaseline and press really hard, what you wouldn't see are these big shear magnitudes. What you would see is my fingertip would just slip and slide far too easily over that skin, and that would reduce the magnitude of shear deformation. So I hope that makes sense. Every blister I ever look at, I've got this in my mind, and I think, how can I implement any of these? Which ones are going to work best? Which ones in combination, and etc. But there's many more prevention strategies than ENGO patches, gel toe sleeves, etc. I don't have time to go through the mechanisms of action for each of these, but suffice to say that in Blister Prevention University, I do. That's the whole point of it. I go through the mechanisms of action and their pros and cons and some ideal usage scenarios. And furthermore, we tie it to what works best for each anatomical location. Now, there's no research on blisters per anatomical location. So this is really from my experience in doing foot care at 6-day ultra marathons, and also a bit of Doug Ritchie's advice as well. So it's really what's needed. You need to think about blisters per anatomical location, not blisters as a single entity with a single solution. And again, that's what we do with Blister Prevention University. Question 3 from Sylvia. Can you please highlight the different types of interventions used and at what stages of blister prevention versus treatment management? I want to tell you or suggest that you simplify your thought processes around blister treatment. Because a lot of our patients and even us as clinicians, we have variable levels of success with blisters. We're kind of all at sea with it. We don't really have a framework, but it's really very simple in terms of treatment. And this is how it goes. If you think about blisters as going through 5 stages, so the first 2 are when we don't have a blister yet, and the last 3 are when we do have a blister. Oh. Okay, so when do we need an antiseptic? When the skin is breached. So it's torn blisters and de-roof blisters. When do we need a dressing? Let's just talk island dressings. Island dressings are appropriate for all of the 3 blisters. So when his roof is intact, torn, or de-roofed. Alternatively, for a de-roof blister, you can use a hydrocolloid. I just spent some time at a pharmacy conference and was educating them around when not to recommend hydrocolloids. Do not use hydrocolloids on stage 3 and 4, because what happens is it sticks like glue to the blister roof, and as you peel that hydrocolloid off, it rips the whole blister roof off with it. And really, hydrocolloids are no more effective than tape at preventing blisters. So hydrocolloids really should only be used for de-roof blisters. But the most important thing, if you want to help that person with their blister get less blister pain and so their blister doesn't get worse, is you've got to implement the prevention during the treatment. So really, prevention is relevant to all blister stages. Obviously, the first 2 stages, they're all about prevention, but even once you've got a blister, remember, when you put a dressing on that blister, you've eliminated rubbing, which is kind of important once the blister has formed, but it's not stopping the blister causing shear. It's still happening under there. And that's why you can put a dressing on there and the blister will get worse. What you've got to do is implement the very best prevention you can find for that anatomical location. That is the key to pain relief and getting that blister to heal, even though you've got to put your shoes back on and keep going. Perlina asks, what is the best thing to use to prevent a blister from breaking open? So what Perlina is asking is, how do we keep the blister roof intact and prevent it from tearing? Very easy. We need the island dressing to protect that blister roof, because think about it, the blister roof is just skin that's lost its underlying support. So it's not going to take much to dislodge that, which is what we're trying to prevent. So an island dressing is required here. And then secondly, we need the prevention that's actually going to stop that blister causing shear. The dressing is not stopping it. It's maybe reducing it a little, but it's still happening underneath. So if you really want to stop this blister from tearing, you need to implement really, really good prevention. If it was this blister location underneath the first MPJ, I would be going for an ENGO patch on the insole for sure. Depending on where I was, I'd go with a Spenco insole if the insole that they had was not really cushioning or shear absorbing, and you could put the ENGO patch on top of the Spenco insole, and maybe I'd put a felt deflective padding if I was at a race situation and couldn't implement a Spenco insole. And that's what it takes to make that blister not get worse as they keep going. At 6-day ultramarathons, I can make a blister not get worse. So it's very, very possible. You just have to implement not just a blister prevention, you have to implement the very, very best prevention, and it's got to be matched to that anatomical location. Nick asks, how to treat while continuing activities? It's implementing the prevention, Nick, in terms of no matter what stage the blister is at. It's the most important thing to negate the blister causing shear. Without it, the blister will continue to hurt and it will get worse in spite of your dressing, and your patient won't be very happy with you. Vicky and Ryan asked, prevention and treatment education. Well, I would also start with a bit of what causes them. So this kind of scenario, finger on the back of your hand, tell them why taping and Compeed doesn't work, because that's what they'll think it should work, because they'll have an overinflated expectation as to the success that should offer. And in terms of treatment, I would go through this. This handout is available. If you go over to pro.blisterprevention.com and do our free CPD course, there's a download that you can do, and it gives you this, and you can print this out and give it to your patients. So this essentially goes through everything we've talked about in terms of when an antiseptic is needed, when an island dressing is needed, when you can put a hydrocolloid on, and the fact that prevention is necessary at all 5 stages of the blister process. So that is treatment. And then you asked about prevention education. I would educate them on the prevention for their specific blisters. So rather than generally, I would hone in on their likely blisters. What are their likely blisters? Any blister they've had before. Any blister you've had before is the one you're most likely to get again. So if they're about to embark on something significant, then they need to know, they need to expect those blisters, and they need to understand what the best preventions are. They need to know how to get them, how to implement them, and really you can help them with that whole process. So let me just see if I've answered that properly. Prevention and treatment education. That's your treatment, and then you educate them. Now, if you're all at sea and you don't really know what the best prevention is for these anatomical locations, go and enroll in Blister Prevention University, because I tell you all there is that you need to know for each anatomical location. I might just pop this in the chat. Okay, Erica asks, what's the significance of sock material in reducing shearing? 3 ways it can work, Erica. It can absorb shear. The thickness of the padding can absorb shear. The thickness of the padding of the sock, so this is only padded socks, obviously, it can cushion. And finally, it can reduce friction. The way it reduces friction is by moisture management. The drier the skin, the lower the coefficient of friction, and therefore the more slippery it is. So it really depends on how effective it is at managing moisture, how much your feet sweat, how long you've got that sock on for. When you think about it, really, the kind of bone dry that constitutes low coefficient of friction is probably not present for very long. So Socks, their absorptive capacity is exceeded at some point, and we can't really be expecting it to reduce friction that much. So probably, if anything, it's more absorbing shear, I would suggest. However, I did a whole presentation on this in June 2023, all about the specific fibers. It's a kind of contentious issue. Sock manufacturers claim a lot of things. We know that moisture wicking can be demonstrated in the lab. We don't really know whether it happens in real life in an in-shoe environment or to what degree. Doug Ritchie is probably the most knowledgeable person about socks in general. And also, obviously, he did that research back in the 1990s that showed it's the thickness of the sock that was the most important thing in helping prevent blisters. And Doug sort of errs more towards wool than moisture wicking for many reasons, but it's just his sort of his feel for it. There's nothing really demonstrated that we can really hang our hat on. I wish there was. Rachel asks, best education to give someone preparing for Kokoda Trail? Great question. First of all, I would keep things really basic and just non-specific for the whole blister thing. So I would talk about what causes blisters to get them out of the idea that it's all about rubbing. And then I would prepare them for their own blister history and to expect these blisters, and I'd help them choose and implement the best prevention for those anatomical locations. Okay, that's got that. We haven't even really talked about Kokoda Trail yet. So that's just for anyone in any situation. Now, the problem with the Kokoda Trail is water. So your feet are going to get wet often and might even get waterlogged. That's a problem when we're using tapes and dressings because the adhesion is going to be compromised. So we can use things like compound benzoin tincture, like we've got those single-use ampoules, which are great for blister kits. And but there are other like Skin Prep, which is an adhesive enhancer. ENGO patches can detach if the shoe gets waterlogged. So that's a potential problem because there's my favorite and the most effective friction reduction strategy out the window. The way I educate around this is I say, let's start with ENGO patches. We might only get a day or two out of them, but we've had the best possible prevention without any downsides for that duration, and then I would have a backup. And my backup for Kokoda is probably for between the toes, it's lubricants, and for the rest of the foot, it's armor skin socks. Armor skin socks are a double sock mechanism. You can, or you don't have to, but generally you wear a different sock over the top of it. So it's a double sock situation. It's low friction on the outside. So that's how I prefer to get friction relief when ENGO patches don't work, when there's waterlogging potential, because armor skin socks, they don't really hold water. The water just sort of flows straight through. And it's really important to dry the footwear out overnight. That involves taking the insole out so it can dry as well. If you're doing Kokoda Trail, they'll always give you a lot of foot care advice. So I've just kind of honed it in at Blisters. But there's obviously a lot of, tinea recommendations and all that kind of stuff. So, Rachel, I hope that answers your question. If you've got any follow-up questions, just let me know. Rachel also asked, EB, that's epidermolysis bullosa, patient recently was recommended they use 30% urea daily for heels, even though they had no callus, and baby oil, plus heavy-duty blister dressing. So I just want to get into that for the moment. Let me just have a quick drink. Moisturizers are not good at reducing friction, and in fact they increase friction. And you'll notice that is when you put the moisturizer on your hands, yes, it's slippery to start with, and then as it rubs in, your hands kind of get tacky, yeah? So that's higher friction. So moisturizers are ill-advised if you're trying to prevent blisters. Lubricants like baby oil, yes, they will affect a lower friction level. We know that they need reapplication every 90 minutes to maintain lower friction levels. My concern here with EB is it's encouraging rubbing between the sock and the skin. And I would rather, particularly with EB, not have anything rubbing the skin. I would rather affect friction relief between the socket and the shoe. That would be ENGO Patches. Just my thoughts. And heavy duty blister dressing, I'm not exactly sure what that means, but essentially that's going to eliminate rubbing. Yes, you want to eliminate rubbing if you already have a blister. Yes, I wouldn't want to implement any rubbing against the skin, even in the best of situations with EB. That's what I would go for. ENGO Patches, that'll encourage the rubbing between the sock and the shoe. With dressings, you can't really be using moisturizing creams and lubricants because, number one, it will retard the adhesion. And number two, you kind of, if you've got the dressing on and you're putting it on the dressing, you know, it's not really going to work. So there's a bit of, it all is a bit, I don't know, there's a few things that are counterproductive there from my way of thinking. But this is how I would attack it. If we're talking purely blisters, so I'd be reducing the friction with ENGO Patches so that I can eliminate any rubbing between the skin and the sock. If the lubricants are on for longer than 90 minutes or 2 hours and friction levels increase, that stands to worsen the blistering process because we've increased friction between the sock and the skin. To reduce pressure and absorb shear, I'd be going for Spenco insoles for plantar shear. I'd go for thick socks and I'd tend towards wool. And I'd maybe go for gel toe devices. Now, the only reason I wouldn't go for gel toe devices is I'm sometimes a bit reluctant to give them to anyone that is high risk and gets ulcerations on their toes. And also like with EB, because if you just put a gel toe sleeve straight on broken skin, it's going to macerate because there's nothing there to absorb any fluids coming from the wound. It's really patient specific as whether I'd go for one of these. But yeah, I would be getting pressure reduction and shear absorption, not just from a bandage. I know with EB, there's a lot of bandaging that goes on, and I'm just assuming that that's more of a cushioning and shear absorption mechanism. But we could do better than that, I feel, with Spenco insoles and thick socks. I think that probably gives you something similar. Post-op dressing. Now, I don't really know where patient is 50, prefers to use as little as possible, but was seeking advice for post-op dressing options. Well, the post-op dressing surely is just an island dressing. So this isn't really a blister question, but I would still be looking to reduce shear in these ways. So, Rachel, I'm not sure if I'm not really getting the question, but feel free to contact me by email and we'll talk about it some more. But I hope that kind of gives it a little bit of perspective. Jack asks, blisters and peripheral neuropathy, diabetics with high-risk feet. Can toe socks be a recommended addition to well-fitting footwear and foot checks in a blister prevention management plan when pain doesn't present as a warning sign? Absolutely, you can recommend toe socks. Toe socks can be great for some blisters. The only thing is with toe socks is you need to understand that you're adding 8 layers of sock into the toe box. So when we're talking about the width, with the normal sock, we've got 1 layer, 2 layers, and that's it. When we've got toe socks, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 layers of sock. So just get a sock, fold it in half, fold it in half again, and see what 8 layers means. It's a substantial increase in bulk in the toe box. So as long as the shoe can accommodate that, it's absolutely a great thing to do. However, it's only a great thing to do for some blisters. I'm surprised when I see people recommend toe socks for any toe blister, and sometimes even just any foot blister. Really, toe socks can only benefit over a traditional sock for interdigital blisters and pinch blisters. For all the rest, it's exactly the same. There's no advantage. So if you're trying to prevent blisters between the toes or like a pinch blister situation, yes, toe socks would be a great idea as long as they fit into the shoe. Maria asked, blister in diabetic patients. Well, first of all, not every diabetic patient is high risk, so it might not be any different to any other patient that you're recommending or educating on blisters. However, their risk status is going to be significant. So, and also their self-care ability. You're obviously going to think twice about lancing if they have high risk or they're unable to reapply antiseptic and dressings. But if they've got someone at home that can do it for them, then, you know, depending on the situation, it might be warranted. As I said, I don't like to use gels on people that have ulcerated toes and who have peripheral neuropathy or who can't see their feet or reach their feet very well, because they're not really going to be able to know, oh, gee, that toe looks like I shouldn't really be putting a gel toe sleeve on it. And the other thing is ENGO patches. If you've got an insole that has significant pressure deflection, so there's big divots in the insole where the pressure deflection exists, it can be difficult because the ENGO patch isn't overly stretchy. You'll need to warm the patch up with a heat gun or a hairdryer just to make it a little bit more malleable, and it will go over those contours. But in some, depending on the level of offloading, it can be difficult to get an ENGO patch on. So there are some things to consider. But really, I mean, you're just trying to reduce shear. Just it's the same for any other patient. Shane asks, sports players, blisters, plantar lesser digits treatment. Okay, I assume we're talking about pinch blisters here, these kinds of blisters. What does Shane ask? Treatment. Okay, well, treatment is, if it's intact, it needs an island dressing. If it is torn, it needs antiseptic and island dressing. If it's deroofed, it needs antiseptic and island dressing or a hydrocolloid. So that's the treatment at its base, most basic, but then you need to implement the prevention to make that pinch blister not get worse. I see heaps of pinch blisters at these ultra marathons. So I'm well versed in kind of what works and what doesn't. The pick of the bunch is easily gel toe caps. I use a cap because the blister often extends towards the apex of the digit. And if you use a sleeve, often we kind of just miss that end of the toe. An ENGO patch on the toe sock. So this is a bit off label, but this is what I find is most effective for pinch blisters when someone has to keep going, especially when swelling is a significant component. As long as they're wearing toe socks, I can stick an ENGO patch to it. It's a bit of a waste of an ENGO patch because as soon as you wash that sock, it's ruined. It's going to come off. But for a race situation where you'll do anything just to get by, and let's say it's day 2 of this 6-day ultra marathon, and I need this pinch blister to not get worse and I need it to not hurt anymore, this is what I do. It's really, really effective. Otherwise, it's gel toe sleeves on top of the appropriate dressing, and it's changing the dressing regularly because think about it, 6-day ultra marathon, very sweaty feet. That dressing, let's say it's an island dressing, is going to need replacing frequently, and ultra marathon runners don't do it frequently enough, but that's a whole different story. Siobhan asked, offloading a PMA blister versus cushioning, what to do when? PMA I'm taking as plantar medial arch, and I've assumed, perhaps incorrectly here, Siobhan, I've assumed we're using an orthotic. So apologies if that's not the case. But I mean, deflective padding, I find it's kind of difficult to make this comfortable in the plantar metatarsal, in the plantar medial arch. So deflective padding is something I don't do often. You could be tempted to change the contour of the arch. So you could put like a little divot in it by heating it up with a heat gun. You'll be tempted also to reduce the height of the arch. So you'll be trying to stop the reduce the pressure, but often that doesn't actually help. Really what we want to do is we want to reduce arch flattening moments, and that can sometimes mean increasing the support of the orthotic. It might not mean necessarily increasing the arch area. Often you'll want to be getting the support more proximally than distally. My lab uses what they call a first ray wipe. I don't know what your lab calls it, where the peak of the arch is more proximal than in the middle. Calf stretches, heel height differential, and heel lifts, because that can cause arch flattening moments. Some pretty easy fixes though. An ENGO patch on the orthotic is an easy fix. It's just going to let that skin move easily in sync with the bone, and a Spenco cover, and even an ENGO patch on top of the Spenco cover. So that's what I would opt for. And then, yeah, I would modify the orthotic to increase the support if need be. Gabriel asks, what should we be sending with people for multi-day hikes? Send them away with knowledge and empowerment. Basically, our patients are completely disempowered when it comes to blisters, and they really are all at sea in terms of their knowledge. Understandably, because to be honest, so are we to a fair degree. Every blister is preventable, and I don't say that lightly. It's just the case. And blisters are more predictable than you think. Everyone thinks they're unpredictable. The most predictable thing that we know about blisters is where you're going to get them, because you've had those blisters there before. So these are the most likely blisters that you are going to get. It's your blister history. So talk through with your patient their blister history. Expect those blisters, help them choose and implement the best prevention for each of those locations, and then send them away with a blister kit, or show them where to get a good blister kit. We've got 3 of them. You can have a look on our site. You might even be able to put together your own blister kit with bits and pieces that you've got in the clinic. So you'll need basically extra prevention items for the unexpected, and plus dressings and antiseptic. So yeah, knowledge and empowerment, that's a big part of our job. Teresa asks, when hiking and a blister occurs in the same spot, is it best to just wrap the toes from the start? What Teresa is identifying here is a blister history. So yes, we've identified a previous blister site. We're expecting to get these blisters. So what we've got to do from here is find the best possible prevention and have it in place right from the start. Now, I'm assuming by wrapping toes, I'm assuming that means tape. I could be wrong, but tape would never be my best possible prevention for any toe blister or any blister whatsoever, to be honest. So you can't, it's not enough just to, I mean, it might be enough just to put any prevention in place, but it might not. And if you really want to stack the odds in your favor, you've got to get the best prevention for that anatomical location. So if you're talking about toe blisters, what are my picks for each of the anatomical locations? For the top of the toe, I'd go for a gel toe sleeve. For the apex, it's usually not that. It's usually that's happening. So it's toe props. Subungual blisters, I would go toe props again. It's usually not that, but it might be. So you will have to assess shoe fit and whether they're doing their laces tight enough to keep their toes out of the end of the toe box. Interdigital blisters, it will be either toe socks or gel toe sleeve. Depends on how many toes we're getting it on. You can't have a gel toe sleeve on really more than 1. You might get away with 2 toes. So if it's all the toes, it's toe socks. If not, then it's the gel toe sleeve. Pinch blisters, definitely gel toe caps. On the outside of the little toe is gel toe sleeve or an ENGO patch on the shoe. I wouldn't choose an ENGO patch if we're putting it on like an athletic shoe that has a very breathable upper, because if they're a runner, they're hiking, if it's going to rain or they're doing river crossings or anything, that water is just going to contact the adhesive part of the patch, and that patch will too easily dislodge. So I'd probably opt for, to be honest, I'd probably start with an ENGO patch, and I'd have a gel toe sleeve as a backup. And under the big toe, definitely ENGO patches and biomechanics. Last question. Danielle asks, how do you apply ENGO patches to the heel counter of the shoes without it creasing? This is a really good question, and I've done a video of this, and I'm going to attempt to play it. So let's just see how this goes. With an orthotic, but the same holds true if you've just got your normal insole in there. It's easy enough if the edge blister is at the side of the heel. You can apply a large oval here widthways to get maximum protection. Creases are fine on the outside, just not where your foot sits. And I'll skip the second patch on the shoe just for the sake of brevity. However, things change when a heel edge blister is around the back. Look at what happens when I attempt to apply a large oval to cover the whole heel cup at the back. It's impossible to get that patch on without leaving substantial crinkles in the patch that will only serve to irritate the skin. This difficulty is due to the curvature of the heel cup from top to bottom and from side to side. These creases are exactly what we're trying to avoid because they will irritate your foot, obviously. We need a smaller patch to avoid these creases. I usually use a small oval patch for this area, but you can also cut a large oval in half, place the rounded edge down, and the straight edge folds over the back of the orthotic to hold it in place. This half large oval provides pretty much the same coverage as a small oval patch. If you need to cover a wider area, you can apply another patch and have them overlap a little. The patches are very thin and this won't be a problem. Let's not forget the second patch this time, the one that needs to go on the shoe. I'm using a large oval placed sideways for maximum coverage. Large ovals back here are easy to apply, much easier than on the heel cups of insoles and orthotics. You could use a small oval if you prefer, because really you're only protected for that area where the two patches line up. Just make sure your blister area is right in the middle of the patch so you're still covered if your foot moves a bit in the shoe, especially if you're on uneven terrain or you play a sport with lots of side-to-side movements. And make sure that patch covers a slightly larger area than the blister itself. Okay. All right, guys, so that is the conclusion of my presentation. Does anyone have any questions?